Is that clapping? There it is.
Oh, hey, it is 9 o'clock, and you've stumbled into the SPSM show. Hashtag SPSM on Twitter. Please do follow the conversation. I'm at Doc Foreman. It was Valentine's Day this week, and I got a pickle.
Oh.
I'm really excited to talk with you guys today. We have a complicated and somewhat controversial topic to talk about tonight, as is our usual sort of topic. And this is one where I don't think we're going to get a lot of conclusive answers. And this is sort of like one of those deals where I'm disappointed in myself. We're going to be talking about apps that prevent suicide risk, and we're going to be discussing, this has been an ongoing discussion sort of for months among SPSM folks who are familiar with technology and suicide risk assessment and standardizing all of that, and there are a bunch of complicated issues around that. In the meantime, this is a really like sort of unregulated part of healthcare, and then there's this, it's like this big public health concern, it's life or death, and so we're gonna be talking about that, but also, I got a yodeling pickle for Valentine's Day. I'm at Doc Foreman. Tony Wood, our IT producer, tell the people about yourself.
Hi, everybody. I'm sorry about the yodeling pickle.
You're not
It wasn't
sorry.
me. It wasn't me. Foreman's children, and she thinks it's great. But I am Tony Wood. I am the COO of Quantify. Here we go again. This is going to be all night like this. This is how this is going to work all night.
This is the only show where your competition is a yodeling.
Wait, but this is important. We talked about it was okay to go full pickle, but you've got to hold off on going full pickle. If you go full pickle too early, you diminish the impact of full pickledom. You got to hold back. We talked about this pre-show. There was a full conversation about.
Fancy. Tell people why you're fancy.
Oh, I'm the chair of the board of the American Association of Suicidology, suicidology.org. Join today.
How did they do that?
Well, if you visit suicidology.org, you can simply join today.
Fantastic. Bart Andrews, Dr. Bart Andrews, introduce yourself.
Good evening, everybody. Dr. Bart Andrews on Twitter at Bart Andrews. I am the Vice President of Clinical Practice and Evaluation at Behavioral Health Response, a groovy little crisis line in St. Louis, Missouri. I'm really excited. We've gotten some positive feedback. We started our iPad project where police officers have iPads. They're getting our clinicians and clients on the line with video teleconferencing out in the field, and we got some rave reviews from the officers, so I'm really excited about that. And I'm excited about the show because we're going to talk about suicide prevention apps. There's an explosion of apps. Yeah. Anyway, I worked on that pre-show. I thought that would work. It didn't. Anyway, there's a lot of apps out there. Yeah, the pickle is definitely better. And I think we need to talk about what it means.
Explosion.
Explosion?
Appsplosion.
I think Appsplosion works.
I think my introduction is over, and I'm ready to pass the baton to the next pickle holder in the group.
And before we pass this to Chris Maxwell, I just want to make a quick announcement that the opinions that we express tonight are definitely our own and not the opinions of our employers. Chris
They
Maxwell.
sure aren't.
Thank you for that.
I assure you that.
Thank you for that setup, April. Yeah, my name is Chris Maxwell. I work for a large suicide prevention hotline here in the United States. You can find me on Twitter at Chris Maxwell with no vowels. It's a little bit of a puzzle I've set up to find my Twitter username, but
there aren't a lot of vowels. In all fairness, Chris Maxwell only has like 3 vowels.
Right.
You don't really need them.
They're just making it easier.
The consonants work fine. So we have to really talk about how we decided we were going to do this show and sort of the complicated feelings that were behind this. So we are so lucky because of SPSM and because we have a wonderful channel and we talk to so many people about technology and innovation and suicide prevention. And because, you know, we've all been involved in projects where people are looking at social media data and suicide risk or using technology to better understand how imminent someone's suicide might be. When we were talking about this all the time, that one of the things that people are interested in developing is an app that lets people know what their suicide risk is and maybe how imminent a death by suicide might be, and what to do about it. And this makes a lot of sense. It really does. Unfortunately, there are some flies in the ointment about this that really bear discussing. And we felt really strongly, and I'm going to own this for me, but I will say we kind of discussed this round and round, that we didn't want to invite people on to talk about products or projects or studies and then either sort of wholeheartedly sell something or sort of tout something that in fact needed a lot more research. And we also didn't want to cast aspersions on anything that people were developing that had maybe a sincere shot at working out. And so we figured that the best way to do this was to really talk about what we know, what we don't know, and what we thought was important for us, questions for people in our field to be asking about this kind of approach, and like sort of going forward what should be done. And we felt like that was the only fair way to address the topic. That being said, what we hope is that a lot of the issues that we raise, in a year, 2 years, 5 years going forward, that a lot of these become addressed just sort of empirically through research and development. I was wondering if I could get the other members of the panel to chime in a little bit about, as we've looked at a bunch of these apps in the last several months, because there's been, like Bart said, an explosion of these kinds of things in the last year. And we'll talk about, we're not just the only ones who noticed this. Like, what thoughts have you had? Bart?
So I've had a lot of thoughts about this, and we just recently had on the NASCOD P&R, we were talking to folks at Centerstone about their app that they're using as part of the program in their Zero Suicide initiative, and that was actually pretty groovy, because that app is actually an app that is only available to clients that are actively in services that are in a suicide care path plan of care, right? And so it's one of the things we had. Was it?
That did not sound like real English. What is a suicide path plan?
Well, that seemed a little judgy. So if people are identified at risk of suicide by a specific identified by this agency, they are identified as a person at risk, and they are put on a suicide care plan, right? So that the treatment then becomes very much focused on suicide prevention. They're on an identified suicide care plan, and they get extra special attention, and we make sure that we're using best evidence-based treatments with those folks that have been identified at risk of suicide. So it's actually a big part of Zero Suicide is this idea of identifying folks. Then when you identify folks at risk of suicide, hey, that's not enough. It's not enough to have some special and be intentional about that level of care and make sure we're doing everything we can to keep them safe and make sure their needs are met. And Centerstone right now is doing an evaluation of how is this app working. And the cool thing about it is that Centerstone has been really transparent about, hey, this worked out well, this hasn't worked out well. One of the things that's really nifty about it is that it connects the users. It's specific to them, right? It's just an app that everybody can download. When the person is told about the app, they're offered it. If they accept it, they have an orientation process. Somebody walks them through how it works, and it directly connects them to their treatment team, which is amazing. And they can actually press a button and it'll instantly get a hold of the crisis team that covers that area that's connected with Centerstone's crisis team. And it has all of the bells and whistles that when we looked at the article that you sent out, April, which was really, really good, it kind of has all the bells and whistles and all the things that the article said you should really have in a suicide prevention app. Get Help Now occurs all over the place, so folks from any screen can get help now and all that kinds of stuff, right? And so I think there's real potential. And so I want to make a distinction. I know I'm blathering on, but this is what I like to refer to as kind of a prescribed app use for suicide prevention, as opposed to kind of like our general, what do they call those things that supplements, right? Like the supplement industry. A lot of the apps that are out there on the open market, there's absolutely no vetting of these apps, right? They're not prescribed. Anybody can go and get them. You're not connected to any specific treatment provider. Nobody's orienting you, walking you through, explaining how everything works. And so it's just kind of a free-for-all, right? And I think that's what we have with a lot of the apps that are out there. And I'll also add that people love to make apps. What did the article said? There's like, they found like what, 100 and some odd, 150.
They looked at 143, but actually for apps sort of in their space, there are thousands, and a lot of them have really happened in the last 1 or 2 years.
I have a legit question for Bart before we move on to the other stuff. The question I have about Centerstone is, I thought I just interjected the question. I had a question. Can
I get a ruling from the pickle? Can I get a ruling?
You have to rate the pickle.
You have the pickle.
I still haven't shut it up. So.
Okay, so Bart, does Centerstone get paid for this? Who pays for the app?
They got a grant. So the grant was actually funded in through I want to say it was either a Tennessee or a Samson-based app. And you Centerstone folks, I'm sorry if I'm getting this wrong, but I know there was funding behind the app development, right?
Yeah.
And the cool thing about this, and this is what I like because we need more of this, the goal is to fine tune this, to vet it, and then make it available to other folks. And actually, since the app is already, the development costs are done, the actual potential costs for other agencies using this app are really, it's low entry, right? The price point is really low entry, very feasible. And so they did have research dollars to develop the application, and now they're in the process of vetting it.
Yeah, so there isn't any direct business model. It's not like they're charging the patient for it. It's not like they're getting reimbursed by an agency. It's just something they're trying to do to enhance services.
You got it. Correct, sir.
Now that shows the spirit of the kind of work that they do. It tells me Centerstone's been a guest in the show. They're lovely people. But the point being that like they didn't do this because they were trying to make the next unicorn app and sell it for $1 billion and go buy yachts.
I think it's the same mentality that patient portals, that healthcare systems use at patient portals. You're creating something new and you're putting some cost up, but the goal is one, it's more effective and should save money, right? Here's a way to connect people via technology that cuts through a lot of bureaucratic for people to get contact and for alerts to get pushed through all in one system, right? So in theory, it's a sort of innovation that doesn't get passed on to the consumer. It shouldn't, because it actually makes everybody's jobs better, and so we cover the cost that way.
Well, a lot of the patient portals that individual people who consume medical services are familiar with were features of EHR and EMR systems that were mandated through meaningful use. So in order to retain their providers' current reimbursement levels from Medicare, Medicaid, they had to provide a patient portal. Centerstone chose to do this because they went out and found them. I think they went out and found the money, and they started to put together a project because they thought it was a good idea for patients. They didn't do it because somebody said you got to do it or you're going to get your budget cut.
Well, exactly, and they're evaluating to see if folks who have access to the app, they're comparing it to other folks that are in follow-up services, and they'll be able to see, hey, did this app make a difference? The feedback they've gotten from folks that are using the app has been really good, and so I think this is really exciting. Centerstone always on the cutting edge of suicide prevention stuff and zero suicide. I can't wait to hear more about what they're doing. But that's kind of the future I see for apps. Is this kind of by prescription where your provider it connects you using this tool as part of the services you're receiving, and that was not the apps that were reviewed in this article. The apps that were reviewed in the article were all downloaded from app stores and available to the general public, I believe, and reading through it fairly quickly. So
and we will talk about there are several things. There are several important reasons why people set it up that way that are sort of about the world, dealing with the world the way it is, as opposed to what would be in the best interest of preventing suicide, because they're just pragmatic hurdles. We'll talk about that in just a minute. I'd like for Chris Maxwell to get to talk a little bit.
One of the things Bart just mentioned was, when it comes to what is the goal of the app, what Centerstone is doing, and even in their evaluation process, they're directly looking at whether or not this is substantially better than the old model. Does this make an actual difference? And one of the first times I ever talked to Tony about apps in general, he said, when it comes to creating an app, the first question should be why. And if it doesn't have its own purpose, if it doesn't add something to the industry, add something to the ability to prevent suicide, if it's just replicating what's already been done, whether it's like, so thinking of like a suicide watchdog kind of app, there are apps out there that can already look at what you're doing online. They're tracking your stuff, and you can look at that later. Trying to develop something like a suicide watchdog app doesn't really add anything to the community, to the industry. So when it comes to finding these innovative things that like Centerstone is doing, they have a very specific purpose. If an app doesn't necessarily add to things or create a solution to a problem, like if there is an app out there that actually goes on to solve the scalability issue of providing therapeutic support, that's great, and that's kind of what this app and some others are doing. But when it comes to just, oh, I'm going to make an app that people can tell themselves whether or not they're feeling bad, I don't know what the purpose of that is outside of what we're already providing in therapeutic relationships or peer support or those kinds of things.
So first of all, there's a whole, I mean, I think that's like one, so of that space, there are a whole lot of apps, devoted to mental health and suicide prevention that don't answer the question why very well. I mean, I think that's really, really fair. There are apps that are a lot of these apps are relatively inexpensive to develop or to build the actual technology. And someone was talking about how, like, Centerstone gets a grant, they don't pass it on to the patients. You were talking about that. And that this is very scalable. And at the same time, one of the really big issues that I have is that the funding, we have the resources to do it, but somebody would have to fund it. Like that clinical apps need clinical trials. So when we are doing something that has a clinical purpose, a medical purpose, like if you are using a device, for example, to measure your heart rate or your blood sugar, they actually have to test that to make sure that it works. And they have to test that it's consistent, and there has to be like a bunch of testing and oversight. And so it's not the building of the app that is expensive. It is the traffic outside my window. It is also, in fact, the testing of it's really difficult, and there's just so very few dollars for research and development and suicide prevention. And there really aren't very many places that are doing any kind of sort of clinical testing of apps. As a matter of fact, one of the few places that I know that are doing any is for the Department of Defense, and it's the the T2 sort of telehealth, the telehealth. Oh, what does T2 stand for? Help me get it right, Tony. I'm totally drawing a blank, and I know and love these people, and we've had virtual.
Yeah, it's Nigel Bush. He was also on the show.
Yeah, we've had these folks on the show. Actually, where somebody builds an app that answers the question why, and then they test it to see if it sort of, meets a certain level of clinical rigor. And so, I mean, that's the actual trick of doing an app that would measure suicide risk, was that it would require clinical rigor, right?
Yeah, definitely. The application of these, the difference between medical care and wellness, there's a big gap. And Fitbit, for example, has been out and proud about the fact that they do not want to be healthcare apps. They don't want to be a medical care company, because they don't want any part of the medical health problem. They want to be about wellness, which is less accountable, not inaccurate, but less accountable to the system and less accountable to this highly regulated, very difficult to integrate into system of delivering care that we have in the United States. So Fitbit just said, no, thank you. We'll just do our thing over here, where we will help people be healthier and do their running stuff and keep track of their steps and their sleep and junk, and that'll be between them and their data. And we're not going to involve ourselves in what doctors want to do and how they want to deal with it, because in America it is far too complicated. It seems that in most of the Western world that is true, but I know about the United States, so I just talk about that. I mean, we have some people on from the UK. Hopefully they can say, but in the US, Fitbit just wants no part of it.
And it's not, I think, because people don't think that these are noble or good things to design and do. It is that, like, There aren't R&D dollars to do it. And I think about like big pharma, where they are putting R&D dollars into giving you a pill. When they give you the pill, they have something to sell you, right? And we talked about the tremendous amount of money that goes into R&D for a pill that can be prescribed. Well, then they can market that, and they have a thing to sell, and they can, you know, mark it up, and they can recover their costs. And maybe only one out of, you know, dozens of drugs that they develop ever makes it to market. And there's still a great return on investment, which is why they take that risk. And there isn't a good business case for paying or funding for-profit funding of clinical trials of these apps. I think that we should do it. I really think that we should do it. I mean, just the facts are that we haven't, and that kind of bothers me. Bart.
Well, there's a lot we're not doing, and it's irksome. When you look at the amount of money we spend in other areas, we've got an ongoing dilemma where there is not a lot of money invested in the infrastructure and suicide prevention. We saw how much money we spent on preventing highway fatalities over the last 10 years, and guess what? We brought highway fatalities way down. And we did that with technology, and we did that with, like, one of the coolest things that we came up with are these side road strips, right? These things that if you go too far to the left, all of a sudden you start feeling this bump and vibration, makes people more alert, recognizes they're going off. So here's this little bitty thing that somebody invented, somebody put some money into it, kind of invented, and we put it all over the country. That's the sort of stuff we should be doing with suicide prevention. But we need money to do that. Even if we invent cool stuff, we've got to have a way to get it out there and get people to adopt it. So that's an ongoing dilemma. I also think one of the interesting things is that sometimes there may be apps out there that people are already using that we could actually use for suicide prevention. So this idea that we've got to keep inventing new apps, right? Maybe we should look at what apps are already out there where people are living and using that could be used for suicide prevention purposes, rather than throwing. I think people have app fatigue, to be quite honest. I just got a new phone, and we're going through, and I'm looking at apps on my phone. How many of those apps do I use anymore? I really use like probably 6 to 8 apps on a regular basis. Yep. So you throw these apps at people, they download them, do they really use them? As opposed to finding a way to hit people where they're currently living, what apps are they currently using? I'll give you a great example. There's an app called Safety Trek. And it was originally developed for campus safety. You know, campus have these blue light phones and these safety phones. So if someone's walking across campus and they feel like they're in danger, they've got to get to one of these phones to call for help, right? And so these developers that are now in St. Louis came up with this idea of, well, hey, what if on your phone you download an app and you literally hold your finger on a button, and if you let go of the button, it instantly alerts either your friends or it alerts the police that you're in danger, and you've got a certain amount of time to respond, right? So here's this thing. It's wildly popular. They've had huge growth. People started using this who have really severe anxiety and are afraid to leave the house. And so they set up a contact list. So, hey, if I let go, it alerts my friends and family that I'm having a panic attack. And people that weren't leaving their house all of a sudden are holding this thing, and this safety net is helping them leave the house, right? So here's this app that was developed for one purpose that people are taking and using it for something that's very mental health related, that's very positive, very powerful, right? And I have a feeling that there's examples of that going on in some of these other apps, but who's looking at this? Who's checking this out?
Well, let's talk about the study that we listed, and this was not about suicide risk assessment apps. And I want to talk about, because we've talked about apps before, but I want to talk about risk assessment some, because that's like a super, I know, it's kind of tricky and it's kind of controversial, and the public doesn't understand it well. But first, let's talk about the Larson study. So a study that's come out in the last year and that's received some press is a study by Larson et al., where they really looked at 143 apps for suicide prevention, and they sort of categorized them. And, you know, they said that there was some dubious effectiveness, some concerns occasionally about messaging or description of method, you know, and so these were ones that sort of, when they could look at the thousands, 143 that they could really classify and look at, you know, once again, weren't well regulated or well reviewed. So we're releasing products for people to use that get about as much review, probably maybe less review, than the supplements that you might be buying at the grocery, which, by the way, if it's not FDA regulated, is, you know,
fully unregulated industry. The FDA currently has a letter, and that's all they have. It's a letter that suggests some guidelines that they may one day certify applications, software applications, and they have some preliminary notes on how they might do that. But that's it. They do not certify, the FDA does not certify software apps for mobile devices as medical devices. They do not do it.
And to be fair, we think that there's real potential that, I mean, that's why we do this show. We've had folks like Craig Bryan on and say, we can probably, or Glenn Coppersmith, like we can probably look at your data, probably do a scan of language that you're using, know some things about what's happening to you, possibly get you to care. Like there are ideas that can be innovated.
Well, you could definitely learn some things about your behavior from your own data.
And at the same time, what is really needed is funding to develop things and then funding for R&D. And I remember, I was really, really lucky to get to listen to folks talking about this at a VA Brain Trust event, last April. And they had a gentleman from DARPA, and he said, if they need money, if they need whatever they need, if they need $5 million, give them $5 million, let them get that tested. If it works, great. If it doesn't, just cut the funding, let's move on to the next thing. I think that we should be aggressively funding things like this so that we can quickly get, have some sort of data about the efficacy of, if there is an app that can be repurposed and it shows good efficacy and it has some certain properties of clinical reliability, then let's start doing that. I really think it should be funded. My worry is that people will develop these and share these, and that folks who, much like in the supplement industry, won't know the difference between something that is well produced and something that's not. And because this could be life or death, that kind of makes me uncomfortable.
Well, it's a complicated market, but pharmaceuticals are complicated with pharmaceutical advertising and promotional activities. People often go into their doctors and request, doctors who have a 7-minute encounter. They go into their GPs and request some medication, and their doctor has a choice to either give it to them because they want it, because the patient wants it, or they get to fight with them over it. Well, that's a problem, right? And those are FDA approved, let alone the Wild West of software applications.
Chris Maxwell.
So yeah, I mean, this whole conversation about how the FDA plays with supplements. I mean, you hear this on any of the ads, like, this is not meant to cure any disease, blah blah blah. Those are the suggested guidelines. We do not have that with apps at all. In fact, I've seen a couple that say this can prevent suicide. This will keep you from killing yourself. Like, we're promising and guaranteeing that you will not kill yourself if you use this app. And that's dangerous. And the study also mentioned that one of the caveats with any of these apps is going to be adherence. Like just like if you're taking Chantix to quit smoking, you have to actually keep taking the drug. For these apps to have any sort of effect, you have to actually use the app. You have to go in and put in what level of risk you feel like you're at any given time. If you stop using it, the effectiveness of the app disappears. And so it's this kind of thing of like, okay, why am I using this? Is it going to be helpful? What situation and context am I using this in? Am I using it in a clinical setting with my therapist? There's a lot of different things with that, but adherence was one of the major things that they brought up.
And I will say that, having used a bunch of different kinds of apps with patients and digital tools with patients, adherence is, I've seen it happen a couple of times, but adherence is a hard nut to crack. We have a question from Lisa Sullivan, and I want for Bart, and we also want to just talk about the issues around risk assessment. Lisa Sullivan asks, does anyone have a good handle on liability in using apps and risk assessment, especially self-assessment? Bart?
I don't know that there's a whole around this. I haven't heard of any cases where an app was sued for liability because someone was using a suicide app and then something bad happened. I think that that's highly unlikely because the suing internet providers, suing app creators is a really difficult thing, because when you download an app, you agree to these these conditions, terms of use that chart out what the app is and what it does and what it's liable for and what it's not liable for. And I'm sure that if you look at those terms of use, it makes it really clear that, hey, this is not a replacement for urgent services, and if you're at risk, these are things, so it covers all these bases. is. As a professional, I would encourage folks to use an app, but I wouldn't ever encourage them to use an app as their sole method of staying safe or addressing suicide thoughts. Just like lots of things that we suggest when working with people as part of a safety plan, we give folks a host of options and see what they're willing to do and what works for them as part of safety planning. And so it's a tool I would consider. And I think if you're using it as a tool as part of that process, I think that the liability for a provider is very limited. I will say that if a provider was working with someone that was at risk of suicide and they said, hey, you just use this app and you're going to be fine, and that's what they documented in the chart, and something bad happened, yeah, I think that provider would be in deep doo-doo, because that does not meet a standard of care in any way, shape, or form. So from a liability perspective, unaware of any lawsuits specific to any app, and for providers making app recommendations, I think that you're okay as long as you're making that app recommendation as part of a comprehensive suicide safety plan that was collaborative in nature, and that was just a tool that was used and not a primary hook or a huge part of the safety plan. That's my long-winded spiel on the liability question.
Excellent. Lisa, I hope you got your question answered, because that was fast and fabulous. Then there's the second piece about just about assessing risk of suicide as low, medium, high. And I want to caveat that with, I do that as part of my job every day. There's a standard for doing that. We do provide training to clinicians who do suicide risk assessment. I definitely help, working with a researcher as part of a lot of people he is touching base with, to figure out how to create machine learning so that they can, look at language to judge suicide risk as low, medium, or high. That being said, are there some problems with the way that we assess risk of suicide? Art?
Yes. So okay. So let's talk about. There's many problems with assessing suicide, and there's some contradictory bits and pieces that I find absolutely fascinating. One, there's a couple of different studies that show doing comprehensive suicide assessments at an agency level, screening everybody for suicide, doing detailed suicide assessments, reduces the suicide rate for that screened population. So there's evidence that just doing assessments doesn't even make any difference what kind of suicide assessment it is, that the fact that you're intentional and active in screening people to see if they're at risk of suicide actually tends to have a protective factor at a population level, right? Very cool. In terms of our suicide, using various assessment tools, for lack of a better word, we suck at it. Clinicians, in terms of their general clinical judgment, are at predicting whether someone will kill themselves or not if they're just using clinical judgment or clinical judgment about
Your
who's going.
sense is not enough. That's all. Sorry.
No, it's okay. Use the pickle. If you've got to use the pickle, use it. So yeah, excellent. So our clinical judgment on who's at risk of suicide without any use of an instrument is really bad. We're not particularly good at it. Clinicians simply aren't good at it. Even when we use psychometrically validated instruments, we still pretty much suck at it. We miss over half the people who do die of suicide that are tagged as high risk. And we miss a bunch of people who are tagged at low risk end up dying of suicide, right? And so our ability, and we talked about it, predictive modeling. We have instruments that were not developed using predictive modeling. They were basically developed using explanatory modeling, and we're not particularly good at predicting suicide. Although people will quibble about this. The other thing that's really interesting about this is that at a recent review of imminent risk by a bunch of national experts, there's only 2 studies that anybody can find. 2. Are you ready for this? 2 studies that looked at predicting risk in the next 30 days. A huge body of research. And are you ready? When we say that we're pretty good, when some of the researchers say we're pretty good at predicting suicide, the scale of time that they're predicting the suicide on is 9 years. We're pretty good at predicting who might kill themselves in the next 9 years, which from a clinical treatment standpoint is useless. It's absolutely useless.
I don't know about you, but when I go to the doctor, I'm really looking for improvement sometime in the next 9 years.
I think it's pretty much useless.
So here's what I'm going to say, which is that the current state of predicting suicide risk is better than nothing, and it needs a whole lot of development. And it may be that using tools like this that are collecting information from folks who have risk and lived experience of suicidal ideation or suicide attempt might get us a lot closer, might get us to like much more precise ways to measure and predict people's suicide risk. And once again, we really need the R&D dollars to do that, to benefit people. Because if we make people think that this is like measuring your blood sugar, where we kind of know if it's high or know if it's average or know if it's low, it's just not that accurate. We're just not there yet.
Well, it's pretty mind-blowing given that there's an entire industry dedicated to suicide prevention that we really can't accurately risk assess.
We counterpoint though. There's a big counterpoint here. So having trashed and been so critical, we're actually better at predicting suicide than we are predicting heart attacks. And when this data was presented to me, it was mind-blowing to me. So in other words, if you see a doctor and your doctor's screening you for heart disease and you've got all these indicators, doctors using the best methods that we have are no better and actually worse at predicting who's going to have a heart attack in this certain period of time than we are predicting suicide in a certain time frame. So it's one of those examples where we assume because it's suicide and it's mental health that it's soft and our predictive capacity is absolutely horrible. The ability to predict a cardiac event is actually really poor. But here's the other thing that this is really key. No physician is held liable for failing to predict a heart attack. A physician will be held liable if they identify risk factors and they don't address those risk factors with appropriate standards of care for whatever condition is presented. But no physician ever gets sued because they didn't predict somebody's heart attack. Mental health professionals get sued because they didn't anticipate somebody's suicide, even if they followed a standard of care. There's this really different expectation. Even though we know how hard it is to predict, providers are held at this level of liability that's just ridiculous. And we're actually a little bit better at predicting a suicide than we are at actual heart attacks, which I found fascinating.
Well, I mean, it is fascinating, but it's also a little misleading. Because the deaths from heart disease since 1980 have dropped by at least half. Even though we can't predict when the heart attack's going to happen, we've dropped the death rate. So people just don't die from them. Half the people are still alive. Now that's because they've figured out better ways to treat heart disease.
They've done things to make to train the public and to make heart disease a lot more survivable. So they've created infrastructure so that heart disease is a lot more survivable. A heart attack is more survivable than it was in the past. And we treat risk factors better, and we catch it way upstream, and we do a lot of other things. That being said, today's topic is about apps that say that they can predict your suicide risk. Now,
they can't.
We're gonna talk about SAMHSA had an app out, and we talked about that, and it's a little bit different. And so, Chris, I'd love for you to talk about the SAMHSA app because it looks sort of like it's the same thing. We want to be really, really clear that something like this is a little bit different. You want to talk about safety?
Yeah. So the Suicide Safe app is SAMHSA's app for behavioral health clinicians. This is the suicide prevention equivalent of going to your doctor, and they're using some tool that has been developed to look at something like risk for heart disease. So these are like the best guidelines that we have right now for behavioral health clinicians to do a really quick assessment, really quick screening when you enter the system like that. It's based off of something called the Safety Card, which is another SAMHSA produced material, but it's long-standing kind of best practices, and the app itself actually presents a scenario for each step of the process with an individual that might come in with a certain ailment or mental health issue. And it goes through like this is what happens with this person in this step. This is what it would look like if somebody came in with this in this step. So it's not just here are the guidelines. They actually give very concrete examples. I believe there's actually videos on there too.
Yeah, and we've talked about those materials. So these are to help really consistently train clinicians, which is different than something that is spitting out a result to one individual. And I just want everybody to be really, really clear on the difference.
So it sounds like it's a checklist. Is that what it is?
Essentially. I mean, it's just like any other screener. I mean, in that sense. You go through.
But for clinicians who are trained to do it already.
Assume that not everybody knows like what people mean in the industry by screener. Assume that we have folks who've not heard of that or don't understand that technology or terminology.
A screening is something that's very basic, that allows a clinician or behavioral health clinician to basically go through a tiny checklist, but it's using the things that are on the checklist are made up of things that we know or have high correlation to high risk or low risk or whatever. So the PHQ-9 and PHQ-2 are two of the most used screeners that exist, and they're 9 questions and 2 questions. And if the person that comes in hits for the high risk or whatever on that screener, then it says go on and do a full assessment, do more with this patient, which is something else that is really I think important with any of these kind of apps. When you go, and I'm still taking an analogy from another kind of health issue, but when you go to Walmart or your pharmacy or whatever, and you do that blood pressure cuff,
every damn time, I love it.
It's like an amusement park ride, but you go and you do it, and it's free. You go and you do it, and depending on what the results are, what does it say? It doesn't say go home, create an app for your heart issue, and then you'll be fine. It says go see your doctor. So any of these apps that claim to have, and I don't know if you can tell, but I'm relatively cynical on the ability of apps to prevent suicide, at least in the current setup. But they need to say something like, okay, now it's time for you to go have a conversation with some behavioral health people. And then that doesn't really help the scalability problem, but that's the kind of thing that we're looking at, I think, at this point.
I mean, as a person who likes to use apps with folks at risk, and that's something like that I do have a lot of sort of rubber meets the road experience. I love apps that generate data that the person I'm working with, that both they and I are sort of checking them really routinely, that we have a plan, like if you see this, then here 24/7, here's who I want you to call and what I want you to do. And that anytime that we're checking in gives me some feedback. So much like doctors might like to see what your blood sugars look like or what your blood pressure has looked like over the last week since we had a change in our treatment plan. I like things like that, and I would love that. I would love for the science about detecting risk and imminence of a suicide attempt, which we think is maybe possible. I know there's some variable thoughts, but it's certainly not off the table. I would love for someone to be doing that, and with it, instructions about how to connect with somebody they know, have a relationship with, their primary care doctor, or provider of some sort, their psychologist or psychiatrist, social worker, case manager, peer support worker, somebody. Like you would want some sort of, you are generating data about yourself and getting insight and feedback, and there's a plan for how we're going to use that information. And you'd have to do a shit ton of R&D dollars. You just would. It's going to need clinical trial. Go ahead.
That's one of the coolest things about the Centerstone app that Bart was talking about earlier, is that they have it set up where you put in your support system, and if you go in and fill out the screen and you pop positive for high risk, it automatically shoots your support system a notification saying, hey, you need to reach out to this person. So one of the things that is one of the cruxes of suicide prevention is access, right? And right now, a lot of our prevention mechanisms are based on people reaching out. They have to be the ones making that contact point. This is why, it's not necessarily the easiest thing for someone to call the hotline. It's not in their moment of crisis. They're not going to go download an app and go, oh, maybe I should start a safety plan. So it's just adding that extra step. It's creating barriers. But something like that, and what you were talking about just now, is exactly where it needs to go. There needs to be some sort of automatic process where somebody is notified, hopefully a support system and a clinician.
And we've talked about lots of different ways to skin that cat, and we've had some of those folks on the show. And just, so we're not going to get in the weeds about that. Bart, you had comments?
I think that Chris had raised a good point. Will people in the midst of a mental health crisis download an app, right?
No.
I don't know. I mean, maybe not. I mean, it's just
a question.
Yeah. So I think it's really interesting when you think about all the different people I've worked with over the years in crisis, the number of different things they do as a way to address their crisis. People love the agency. And so I actually think that if there was a way that you could, if you had an app that had some real good evidence behind it that people could download to get immediate assistance anonymously via this app, maybe artificial intelligence interface, I don't care what it is, I think people would give it a shot, to be quite honest with you. Jobs was talking about how Jobs is doing a study where they're looking at people being administered an artificial screening and intervention in hospital EDs. And they found that the more severe people's suicide risk was, the more comfortable they were into an artificial intelligence interface than they were to a human being, right? So I think there's lots of interesting things about what heights of a major mental health crisis or a suicide crisis. And it looks like the demands of being in someone's space face to face can be really overwhelming to folks. Is it possible that folks could download some really cool app that could help them in that moment better than a live person? I'm open to the possibility that it could be.
And I'd like to point out that downloading an app, which is something I think we're going to do less and less, is something of the last few years, like this sort of one sort of way that we're sort of interfacing with this digital technology. But increasingly what's happening is that there are applications that are embedded in platforms that we're regularly on, like Facebook or Gmail, etc. And so it may be that what happens for public health is that that there's some sort of something baked into portal everybody's on, and that you and your doctor sort of opt in, and it's something that you do in office, and that it's opt in, that it's something that's had a clinical trial, that we are improving the standard for detecting risk, doing consistently, doing it more accurately, and having it sort of baked into the technology that you're already using every day, which is like sort of my dream or my hope.
I think it's a great hope. I think things are moving at a pace with artificial intelligence. I anticipate that within 5 years, we'll have these artificial intelligence, like personal avatar assistants that basically crawl through all of our digital sphere and advising us based on all of our data, right? I think we'll have these interactive avatars that kind of ride along with us in our digital space wherever we go. That we could use as a tool for all this sorts of thing. And the technology is getting closer and closer to this being a realistic thing. And I just love this idea, right? Your little AA pal hanging out with you all the time.
Did you ever see Gem and the Holograms and the little synergy, the little hologram that popped up and knew what was going on was in Gem's earring?
I got no idea what that is.
Not that it has to be part of fabulous jewelry and rock and roll, but it wouldn't hurt.
What about Kit the talking car?
What about
Gem and Holograms?
What about Kit the talking car?
Or Clippy from
Clippy.
No, this is
Clippy,
come on now.
Is definitely
It
the
looks like
solution to
It
suicide.
looks like you're at high risk for suicide.
Yeah. Could you
Don't minimize this with Clippy and with Kit from Knight Rider. Don't. You just
Knight Rider was a fun series.
I'm calling pickle on this. Cole, right now.
But seriously, folks, I just checked to make sure that I was right. So I did cheat a little bit, but cardiovascular disease, NIH funding alone, annually $400 million.
Which is
And suicide is
7 times.
And suicide is what, Tony?
I get
$10.50, I believe.
So that we can all get
somewhere in there in the 1050 area. So
and wait,
that's
Tony.
not all the private drug companies. That's not all the other people in the cardiovascular business. That's just NIH research funding alone.
And Tony, of the 1050, 850 goes to teen suicide. So
I'm assuming so. That's
So
where I'd put the
that leaves us a good 2 bucks to work with on the adult suicide problem.
I love Lisa. Lisa Sullivan says, Alexa, what's my risk of suicide today?
Yeah. A product never coming out of Amazon.com. Ever. Ever.
But
if they are sane.
But maybe. So the issue is that there are all these companies that are really going to embed technology and these sort of interfaces into like so much of our lives. It seems to me that they're gonna have some healthcare functions. I think that is why you have people like Tom Ensel going to Google. This is why you're seeing folks in the mental health space going into all these major companies. Is that it is going to get baked in somehow. And
the largest technology companies in the world have healthcare arms. They all have them, but you notice if you go and look that they're not out there dropping stuff into the App Store. And the reason why they're not doing that is not because they're not capable of doing it. It's because they can't figure out what's a good idea. And these are some of the smartest people on the planet.
And you know, one of the things that happens is when tech folks reach out to us, and we are so lucky, some of the SPSM alum, to at least have some visibility. So folks reach out to us. And I think that's one of the big misconceptions from the technology community and from the public health community, that there is a way to, like, you know, stick a thermometer in and measure your suicide risk and tell you what to do. And we would be doing, it's not that we can't, like Bart's like, we certainly have a sort of, we're better than chance. We just really should be keeping people in the loop about how much R&D needs to be done so that we could do that more accurately. Because right now, our ways of doing that have a lot of noise in them, a lot of error in it.
We need data. We need folks to donate their data to organizations like ourdatahelps.com, because one of the biggest challenges that we have is we don't have enough data. Now, I will share what managed care companies will tell you. They don't say this, but managed care companies with big data, they can actually predict who's going to suicide within 30 to 60 days based on looking at overall healthcare records and all their, they don't know what to do with this. Here's the problem. They don't, what do we do with this? I'm willing to bet that places like Google and Facebook and Twitter actually can tell you pretty good that this is somebody that's in major distress and is in deep trouble. Nobody knows what to do with it. What do we do with it? What are we going to do? Right? So we have two problems. To do that, and we need more data by folks that can actually do something with it and develop some ways to intervene. I love the idea of an app interface that connects across people's social media streams, because one of the things we saw this was really cool. We saw this in Phoenix. You were there, Chris, and this officer was showing how they identify people at risk of suicide on Facebook Live, Instagram, and that people have multiple different profiles and they show different sides of themselves on different apps and different, right? So you look at them on Twitter and they look fine and dandy, and then you go to their Instagram and they look really depressed and near suicide, right? So you can't just focus on one app even. You got to be able to kind of comb the whole person's digital footprint, because people will show different things in different places.
And be really clear, I think if there were actually like serious funds for R&Ds that were serious as the public health threat of suicide, that we would start to find out which signals were really reliable. Like right now, we're all looking at like, what are ways for us to measure this? What signals should we be paying attention to? We've come to, in medical care, a lot of standardized tests and ways to look at biological, signals. We probably need to find out which of the signals are more reliable. So like, because right now we have the kitchen sink method of detecting risk, where we're looking at a whole bunch of stuff. And it may even be complicated enough that not all the same signals are appropriate for different people. So we probably have to do some very complex science to understand that in order to deliver the technology products so it says, so you say, Alexa, when my suicide risk gets to 98.3, schedule a walk-in with my therapist and send an email to my boss letting me know that I'm taking a sick day. Wouldn't that be fabulous? Might be possible. Need to do the science to make it happen. Bart, you're giving me Bart face.
I love it, and I do think that we have the tools available to be able to, particularly who people are active on social media, to have a good read on their mental state, their emotional state, and when they need some prompting or so look, there's no doubt to me that when we talk about suicide risk, it's not we're not trying to interrupt an event as much as we're trying to interrupt a pattern of behavior. right? And so there are these patterns and these signals. There's these patterns that we need to be interrupting, right? We've tried to look at suicide as this: either you're at risk of suicide or you're not. And the models are showing that on up and down, it can change rather suddenly, and there's these patterns of behavior. And I think that we've got the data on folks via social media to get a sense of what their emotional space is, and to send out alerts and do things to kind of interact with them and help them in the moments when they need it the most, in real time, for goodness sake.
And be really clear that our ways of helping, because we weren't able to sort of get the timing really right on when people need us. There are like some DBT methods, some crisis intervention methods, but probably we would find out we would probably have to also do the R&D on what the intervention is that really, once we could measure it, then we would know you do this and then it drops, or then it stabilizes. But we'd have to, get a really consistent measure that could be replicable, that's at scale, that everybody's using, yada, yada, yada. I mean, just like measuring anything, like that is really where we are with suicide risk. And we think it is, I think, I'm gonna speak for myself and then we're going into final thoughts. I think it is really wonderful, this appsplosion in the suicide prevention world. One of the things when I was doing the content for this week's show, and I was like, when we started this, and what year was that? It was 2013, right? When
I think Lincoln was president.
Right.
What year was that?
And it was 4 years ago, and that just this appsplosion really had
a nation divided.
This has happened like while SPSM has been on the air. And this is why we do SPSM, which is to talk about things. Larson does a study about 143 apps, thousands are being developed. And we need to talk about this issue at the speed at which it's happening, because the technology changes so quickly. But the bottom line is serious dollars for a very serious research program into doing this kind of work. And that's going to be my final thought. I'm going to round the horn. Tony Wood, final thoughts.
February 19th, 2017. There is no solution to suicide in the App Store.
Ooh.
That's
memeable.
That's my final thought. Also, 420 years ago, our fourth. Yeah.
I think I finally found like the Muppet Show hook for SPSM. Chris Maxwell, final thoughts.
My final thoughts are that at this point in time, it seems like the most helpful apps are the ones that can be integrated with therapeutic care that is ongoing, or specifically for clinicians. And let's, by all means, keep creating those as long as they're innovative. And let's keep using the ones that we know work for us and work for our clients and our patients and the people that we talk to. Use what works for the individual, please. So if you find an app that really doesn't have any sort of like clinical validation or anything, but you find it helpful, keep using it. And then in the meantime, hopefully we'll start integrating with social media and make things a lot more predictive.
And Bart Andrews.
Final thoughts for me. One, we don't prevention apps. I'm going to say this. We don't invent any more new apps. Let's take a step back. Let's look at how we can connect with current social media streams and use social media platforms to predict suicide behavior and intervene in those ways. Two, let's look at what apps are out there and let's do some research on those apps and let's get behind some things that are working and consolidate around some things that we know that we can do instead of adding another 100 or 200 suicide prevention apps so that you can have your name on an app and it can be on an app store. That's my 2 cents.
And we're rounding the corner. I just want like a final thought. We are all about innovation and inspiration at SPSM, so we don't want to tell anybody to stop believing. We think that this is possible. I think Lisa Sullivan, and I had bookmarked this to mention, and I forgot to work this in earlier. She said, that it's not just the woefully low funding, she says to me on Twitter, it's also the funding approach, that there are short grant cycles, there are sort of shifting targets. These targets aren't based on sort of like some sort of scientific programmatic plan for how we're going to solve this problem. They're sort of based on all these sort of political feelings about suicide, and she's absolutely right. We really need to start taking a structured, planful, programmatic approach with serious dollars that as structured and as serious and is funded at the intensity that this social problem exists at. Tony?
And this and many more topics will be discussed at the upcoming American Association of Suicidology Conference in April, which you too could attend in Phoenix, Arizona.
Like, seriously, especially if you live in the area, we hope that you will drop in. Like, if you are a person who is not planning to like attend the conference proper, but you know we're going to be in your neck of the woods, like you totally need to reach out to us on Twitter and like hit us up, come like hang out. We love to see folks who are really familiar with the SPSM community, and there's going to be a lot of SPSMers at that conference. And until we can figure out a way to fund our own sleepaway camp, AS Phoenix 50th anniversary conference, that is SPSM sleepaway camp as far as I'm concerned. So we're definitely excited about that coming up.
Boom.
Boom. That's it. You've had another hour. I want to let you know next, I feel like I say it's a very special episode. I want you to know that we put a lot of thought as a team into what we really need to be discussing, why it is important, and we get excited for each and every episode. Totally the truth. Next week is really going to be quite special. This is the first time that I've ever done this, and it makes me feel a little bit like a lone gunman. But we're going to do the SPSM Manifesto episode. We have been soliciting what we think are important talking points in the suicide prevention, innovation, technology, and social media sort of intersection. And what we think are going to be the talking points for the immediate sort of upcoming future, like what we think people should be talking about, should be advocating for, should be on people's minds. And we have solicited lots of cool stuff. We're going to be presenting as much of it as we can cram into an hour, and I can already tell you that I'm really worried about the density of stuff. So much like Luther nailing things to the door, we have got stuff to talk about next week. If you want to know what you should be talking about during this upcoming conference season and in your networking, next week is a show to tune in. Have a great week, y'all. Take care.
Peace out.